Hi, and welcome to our Hot Topic session, A Healthy Heart Starts With You. Today's program is sponsored by Methodist Health System, and our speaker is Dr. Tracy Jurens. Dr. Jurens knew from an early age that she'd grow up to be a doctor. Her love of science and social interaction made a career in medicine seem like a no-brainer. And over the years, the challenge of determining a diagnosis for so many individuals with complex conditions has solidified her love for cardiology. After graduating medical school and completing her residency at Creighton University School of Medicine, Dr. Jurens received her cardiology fellowship at Mayo Clinic in Rochester, Minnesota. She currently sees patients at Methodist Physicians Clinic, West Roads Office Park. Please welcome Dr. Jurens.
Thank you very much. It's so good to be here and talk about such an important topic. The topic is called A Healthy Heart Starts With You. And really, when we're looking at this, we're looking at steps to lower your risk for heart disease, and that's primary prevention. I think you can divide this out into two areas, what you do at home and what you do with your physician, which we call shared decision making. Let's start at lifestyle and what you can do at home. This is a healthy lifestyle. Exercise, of course, is an important topic. The American Heart Association and the American College of Cardiology recommend 3 to 4 sessions per week. The session should be around 40 minutes per session. They talk about moderate intensity exercise, which we'll go over in the next slide, but also to consider strength training at least 2 days a week on top of that for additional health benefits. So some definitions to help us understand exercise would be sedentary is pretty obvious. It's sitting, watching TV. Light exercise would be walking, pretty slow pace, cooking, light housework, whereas moderate exercise would be brisk walking, biking, dancing. Vigorous exercise would be jogging, biking, and that would be greater than 10 miles per hour, singles, tennis, or swimming laps. We do note that there's an inverse relationship between moderate to vigorous exercise and atherosclerotic wrist disease. And so what that means is the more intense your exercise, the lower your risk of atherosclerotic disease. Though I wouldn't, I think that any exercise is important, and I wouldn't let that play a part in decision making on what to do for exercise. No, there's no lower limit. Some exercise is better than none. So a lot of my patients are fairly new to exercise, and so the important thing is to set a realistic goal so you don't get discouraged. Start slow, work your way up. So this would be maybe starting with a slow walk, maybe 5 minutes a day, and then every couple days adding a minute to build up your tolerance. And again, not to get hung up on the moderate or vigorous exercise, walking is still great. And so another focus would be diet. Diet, there's all kinds of different diets out there. There's different recommendations, but in general, looking at for heart disease, we would say a diet high in fruits, vegetables, nuts, whole grains, fish. Try to replace the saturated fats for polyunsaturated fats. So saturated fats would be some of the oils, butter, lard. Polyunsaturated fat, a good source would be olive oil. Would also be fatty fish, so that's high in omega. Also, we talk about decreasing sodium, avoiding trans fats, so that would be the baked goods. Also, there's some new evidence a plant-based diet may be beneficial, and I would say it depends on your plant-based diet. So a good plant-based diet would be high in fruit, nuts, and vegetables. But you could theoretically have a plant-based diet with refined grains and sweets, and that would not be the type of plant-based diet that would be beneficial for heart. The American Heart Association has a Simple 7, and you can look up different recommendations. This is just a screenshot of their website, but it gives kind of an example of how many servings a day, how to read nutrition labels, and ways to be successful. When you're looking at cardiovascular disease, I typically recommend the Mediterranean diet. It's really has the strongest evidence for reduction in atherosclerotic wrist disease. There's been a couple trials that I show here that have shown benefit. This would be a diet that's high in fruits, vegetables, whole grains, olive oil, fish, and seafood. You can still in moderation have poultry, eggs, and cheese. And then on special occasions, you can still eat red meat and sweets. Also, when we're looking at cardiovascular diets, the DASH diet would be one that also comes into play. This would be eating healthy that would lower your blood pressure. And so dietary approaches really to reduce blood pressure without medications. Reducing sodium is important in this diet. And then on the flip side, eating foods rich in potassium. So these would be bananas, sweet potatoes, tomatoes. You could actually reduce your blood pressure in a few weeks, sometimes as much as 8 to 12 points if you follow this diet. Details of this would be a sodium less than 1,500 milligrams a day. So watch out for these processed meats, frozen meals, soups and chips have high amounts of sodium. Eating whole grains is important, fruits, vegetables. So a lot of these diets have overlapping theme here. The fats, you want to do 2 to 3 servings a day. You still need fat. Saturated fats are preferred, but avoid trans fats. Polysaturated fats are preferred to the lean meats. Sweets, 5 or fewer per week. Tobacco is very important. It's a very preventable cause of atherosclerotic disease. We do recommend total abstinence. Even low levels of smoking increase risk. And so we try to eliminate the risk completely. In adults who do smoke, I think a combination of behavioral interventions plus the possibilities of pharmacotherapy is recommended to increase the quit rates. So some of the pharmacotherapy that we might use would be a patch. The downside could be local irritation. Gum or lozenges can help. These could cause hiccups or upset stomach. Nasal spray, oral cartridge, and then some medications might include bupropion, which can decrease anxiety and Chantix. The goal here is to have a plan. You set your quit date, choose your method, so maybe cold turkey or each day reducing the number of cigarettes. Then talk with your provider to come up with that plan, and then also plan ahead. So have a backup, so when you feel the need to smoke, that you have something else you could do, like go for a walk or chew gum. So now we'll get to the part of shared decision making. This is where you come in and talk with your physician about how to decrease the risk of atherosclerotic disease. And in this, I think that one of the main tools that we use is assessment of a cardiovascular risk. So this would be a score of some sort. I use the atherosclerotic risk score, and that's really what the American College of Cardiology has suggested. This uses age, gender, race. We plug in your total cholesterol, HDL or good cholesterol, systolic blood pressure, and then these are yes, no questions. Are you on treatment for blood pressure? Do you have diabetes? Are you a smoker? And then you can come up with a score based on your answers. In adults age 40 to 75, we would calculate this 10-year risk score. We also call it a pooled cohort equation. However, in adults 20 to 39, there's not a lot of data on this score, so we end up looking at individual risk factors, and we could estimate a lifetime risk. This score can allow us to understand any benefits of treatment without the harm of over-treating patients. Our guidelines, in fact, whether we're looking at cholesterol or even hypertension, use this score. Another age group that's not really associated with this score would be age over 75, and this is really an individual discussion of appropriate therapy based on the comorbidities, so other risks and life expectancy. So in the score, the majority of the score would be 40 to 75-year-olds. You can divide this into low, borderline, intermediate, and high risk. And then hypertension, we get a percentage of your score as well and can guide our treatments. We kind of talked about age 20 to 39. Again, we're looking at traditional risk factors every 4 years. This would be smoking, diabetes. We're looking at blood pressure and cholesterol. And then we could also do a lifetime or 30-year risk score, which could use we can use for communication strategy to enforce lifestyle recommendations. There are some groups that this underestimates risk. These would be people who have inflammatory conditions, rheumatoid arthritis, lupus, HIV. There's some suggestions socioeconomic disadvantage may underestimate risk. And then what do we do about this borderline risk group? And these are the percentages, which we'll talk about here shortly. For those borderline group, we can use risk enhancers. So family history of premature atherosclerotic disease, that would be males less than 55 and females less than 65. And these are first degree relatives. So mom, dad, and siblings. Also, patients who have primary hypercholesterolemia, these are LDLs, are bad cholesterol that are very high to begin with. We may use that to influence our decision. Metabolic syndrome is a risk enhancer. These are patients who have high waist circumferences, elevated triglycerides, glucose, and low good cholesterol. Chronic kidney disease, chronic inflammatory disease. In women, premature menopause is a risk. And then pregnancy complications like preeclampsia. We can use certain biomarkers. CRP is an inflammatory marker that we sometimes use. And then some detailed cholesterol like LP little a and ApoB are important. Also, calcium score, which I will go over later, can sometimes help with our decision making in statin use or cholesterol treatment. There's diabetes that we look at closely. So glucose is produced with carbohydrates and sugars, and it goes from the digestive tract to the blood. Insulin usually helps this into the cells, but there can be insulin resistance. And so you can get elevated glucose in your blood. We check this with fasting levels. Normal would be less than 100. Elevated would be 100 to 125, and diabetes would be 100, greater than 126. There's type 1 and type 2. Type 2 is we focus a lot on because we can influence this by diet, exercise, and this is the majority of the population of diabetes. For diabetes, we recommend following a diet. The Mediterranean diet's a good one. We, of course, look at carbohydrate intake. We prescribe an exercise plan and aggressive treatment of other risk factors like high blood pressure, tobacco use, and then occasionally medications. Cholesterol, when we're looking at this in detail, the question is when to add cholesterol medications. We primarily use statins, though there are a lot of other cholesterol medications. There are certain groups that we would just add a statin and wouldn't really necessarily look at the risk score. One would be just a baseline LDL or bad cholesterol greater than 190. We typically use intense statin therapy. Those who have diabetes and are 40 to 75 years old, we'd use moderate intensity statin. Unless they have high risk score, we might change them to a high intensity statin, and that's just the dose that we use, the milligram dose. Again, those age 20 to 39 for it, when we're looking at do they need cholesterol medication, we start off by encouraging the healthy lifestyle, but we may consider adding medication if there's premature coronary disease or with an LDL greater than 160. In the majority of the patients that are 40 to 75 years old, again, we look at this score and we classify them. Low risk really does not require any treatment, typically for cholesterol, but the borderline to intermediate risk, we may have to look a little further. High risk group that calculate a very high score, our risk for atherosclerotic disease, we initiate statins to lower that LDL or bad cholesterol greater than 50%. In that intermediate group, I use coronary calcium score, not infrequently. What this looks like, what this looks for is basically calcium that might have deposited in the coronary arteries, and it can refine our risk and treatment with statins so that if a patient is borderline but has a high coronary calcium score, we'd be more enthused about adding the cholesterol medication. Whereas if the score is 0, probably not much benefit for adding that statin. The benefits of coronary calcium score. So some patients are sometimes reluctant to take it, and if they know they have calcium that has already developed, it can help in these reluctant patients in initiation of statins. Also, there's some older patients that are looking at primary prevention, may have risk factors and question whether they need statins, and so the coronary calcium score could help there. But again, this middle age group that have that intermediate score, that's where I think it's the most helpful. Hypertension, normal blood pressure would be defined as less than 120/80, but we still continue to promote that healthy lifestyle we talked about early in the talk. Elevated blood pressure would be 120 to 129 over less than 80, and here we continue to promote the lifestyle, but not necessarily treat in most patients at this stage. Stage 1 hypertension would be 130 to 139 and 80 to 89. This is where that risk score comes in handy. So if the risk score calculates higher than 10%, we'd be starting medications at this in this patient population. Greater than 140 and greater over 90, we'd continue to use lifestyle as well as medications. When you're looking at what do you do for lifestyle non-pharmacologic treatment, weight loss, you could lose some of that blood pressure. If for every pound you lose, you can expect some loss in that systolic number. Healthy diet, we talked about. Reducing sodium can lower those numbers significantly. Physical activity, moderation in alcohol. And if you do lifestyle, you would want to reassess this in 3 to 6 months. I'm going to skip to aspirin here. This has been kind of an important topic and in the news over the last couple of years. We've really reduced our use of it in primary prevention and really only use it in the setting of elevated atherosclerotic risk factors, but also acceptable bleeding risk. And so bleeding risk really increases in those age over 70, history of peptic ulcer disease, low platelets, kidney disease, or non-steroidals. We would be more reluctant to use aspirin in that group. But you have to balance it with your atherosclerotic risk. And so I think this is a good conversation to have with a physician and looking at bleeding risk versus your risk of coronary events. The dose, we do recommend less than 100 a day. There again is no justification in routine use for primary prevention. Watch out for adults greater than 70, and in adults less than 40, probably insufficient evidence. There's 2 sources I typically recommend for patients that they can go on the website. One is through the American College of Cardiology, is CardioSmart. And this you can type in your topic and it'll give you information. And then the other one is from the American Heart Association. It talks about Life Simple Sevens. So basically looking at all the ways you can decrease the risk yourself. And you can click on each of the ones that you would want more information on. And it's a nice summary of each of those. And that's all I have.
Thank you, Dr. Jurens. So insightful, and these hot topics always spark a lot of questions. So if you don't mind, we have a few we'd like to throw your way.
Sure.
The first one is, what age do you recommend starting a conversation about your cardiovascular disease risk with your primary care physician?
Oh, that's a really good question. I think it's never too early. I think that depending on your age would be to depend on how the topic is, but I think as you reach your 20s, certainly you should start having the conversation, and then your physician can help guide you for what further talk or labs or tests that are needed. So never too early, but certainly in patients who have family history, strong family history, earlier the better.
Okay. And then at the beginning, you mentioned a few diets. If
Yes.
someone is wanting to lose weight, but also reduce their risk of cardiovascular disease, is there one that you would recommend more than another?
Yeah, I get this question frequently as there's so many different diets. Like I get asked about the keto diet a lot and such. I think the bottom line is a Mediterranean diet, in my opinion, is still good for weight loss. It's just a combination of eating the right with Mediterranean diet, but also portion size. And so you're looking at caloric intake for weight loss. And so I think you can still follow a Mediterranean diet, but look at your caloric intake a little more detail in order to lose the weight.
Okay. And the last one is, if someone has low blood pressure, but thinks they can eat all the sodium that they want to because of that low blood pressure, what would you say to that individual?
Well, I do have a few low blood pressures that I do recommend a little more sodium, but you do have to be careful. I think a low blood pressure, that's another question that comes up sometimes, what's too low? And some people just run low blood pressures and they feel fine with it. I think it's in those patients who don't feel good, run a low blood pressure, that we do recommend a little more sodium. I mean, there are times where I've had to prescribe sodium tablets, but I would say in general, the sodium issue is still important to, you may not have to focus on it so much if you run a low blood pressure, and you may need a little more sodium, but I think as long as you're in discussion with your physician that you're doing it appropriately.
Okay, well, perfect. So thank you, Dr. Jurens, and thank you to Methodist Health System for being the presenting sponsor of the American Heart Association's Go Ed for Women campaign. We just really appreciate you guys and the knowledge you've shared. So this concludes our hot topic session, and we hope that everyone has a great rest of their day. Thank you.
Thank you.